I kindly invite Dr. Udayvel, consultant anesthesiologist and intensivist, Preeti Hospitals, Madurai, to present the topic on additives latest updates.
Good afternoon. For the next 10 to 15 minutes, we will have a brief discussion about the additives in order to prolong the duration of motor as well as the sensory block. Before going into the session, I would like to thank my teachers, seniors and colleagues and the organizing team comprising of Dr. Sendil Kumar sir, Dr. Balaji sir and Suresh sir for giving me this opportunity. Let's go into the session. So the most common plan we have is to mix the local anesthetics by mixing the fast acting like lignocaine with the long vacaine or ropivacaine in order to achieve the rapid onset and prolonged duration and to reduce the total dose. Even though it has faster onset like 5 minutes when compared to using either bupivacaine or ropivacaine alone, but the duration of analgesia has shortened when compared to using the local anesthetic as a sole agent for neuraxial blockade. So what really happening is the mixing of the local anesthetic leads to dilution of the local anesthetic. So the concentration gradient at the level of the tissue is going down. So the less concentrated drug is actually reaching the voltage gated sodium channels and it has led to decrease in duration of the local anesthetic. And it also lead to change in the pH, which leads to more of unionized fraction of the lignocaine, which we are using to fasten the onset. So there will be at last slow onset and shorter duration of the block when compared to using the local anesthetic as a single agent. Instead of this, we can actually use the ultrasound and we can precisely give the injection beneath the sheath or epinurally to prolong the duration of anesthesia. Coming to the second agent, which is the alpha-2 agonist, the main mode of action is by NMDA modulation leading to the systemic effect, and it also has the central mechanism at the dorsal horn of spinal cord and the locus ceruleus. It also has synergic local anesthetic blockade and vasoconstriction, which lead to prolonged contact time with the nerve fibers. It also, the main mechanism is the hyperpolarization of the postsynaptic nerve terminals, which leads to increased threshold of nerve action potentials, thereby prolonging the duration of the block. Mainly the two agents, one is clonidine and another one is dexmedetomidine. Clonidine at the dose of 150 to 300 mics and dexmed at dose of 0.5 to 1.5 microgram per kilogram. We can either use it perineurally as well as intravenously. Both have similar efficacy, but the main disadvantage using perineurally as well as intravenously is the sedation, bradycardia and hypotension. Coming to the most common and well-versed drug used for prolonging the duration of analgesia, that is the dexamethasone. The main action is it acts at the glucocorticoid receptors at the sensory nerve axons, which leads to increased expression of the inhibitory potassium channels, leading to alteration in the action potential and prolonging the duration of blockade. It also has the anti-inflammatory properties as well as vasoconstriction, leading to the prolonged contact time with the nerve fibers. So dexamethasone actually prolongs the duration of action by 8 hours. So we can use 1 milligram to 8 milligram either intravenously as well as the perineurally, but majority of the studies shown that 4 mg is the ceiling dose. When we are using intravenously instead of perineurally, there is also additional benefit of decreasing the incidence of postoperative nausea as well as the vomiting. Main thing is it has some compatibility issues with the ropivacaine, so we have to use along with lignocaine or bupivacaine when giving perineurally. Coming to magnesium, its main mechanism of action that we have thought in case of prolonging the duration of blockade is competitive NMDA antagonism alters the calcium influx, membrane hyperpolarization and the nitric oxide pathway. Dose at the rate of intravenously 30 to 50 milligram per kilogram and perineurally at the dose of 150 to 500 milligram can be used. Even though it reduces the postoperative analgesic as well as the opioid requirement at 6 and 12 hours postoperatively, actually the risk outweighs the benefit, so it's actually not recommended for routine usage to prolong the duration of peripheral nerve blockade. The main toxicity is the temporary paralysis as well as neuronephrotoxicity. Coming to the ketamine is not recommended for prolonging the duration of local anesthetic. Analgesic benefit is unreliable, at the same time reliable improved block quality is not achieved. Neostigmine, again, it's not been recommended and no studies have proven it has prolonged the duration of sensory as well as the motor blockade. but it has increased the risk of nausea and vomiting and gastrointestinal side effects along with the neurotoxicity, and it has some compatibility issues with the drugs we are using for blockade. Coming to the opiates, there are many studies compared tramadol with the dexamethasone, tramadol with morphine, fentanyl. None of them have showed any act on prolonging the duration of sensory as well as the motor blockade, except buprenorphine at the dose of 300 microgram intramuscularly. That too, it increases the duration of analgesia by 9 hours, but at very, very expense of 5-fold increase in postoperative nausea, vomiting and itching. So even though it prolongs the duration of analgesia, it's not been recommended for prolonging the duration of sensory as well as the motor blockade. Coming to NSAIDs, there are several studies, but none of them have proven to be prolonging the duration of sensory as well as the motor blockade. So at last, the drugs we have discussed are being used to prolong, in order to prolong the duration of sensory as well as the motor blockade, but none of them is FDA approved. All these are off-label use. So among these, dexamethasone increasing the duration of analgesic by 6 to 8 hours. It has incompatibility issues with ropivacaine. IV has some potential benefit like decreasing the incidence of postoperative nausea, vomiting comparing to perineurally. The most commonly recommended, commonly used off-label drug is dexamethasone, and second one is the dexmedetomidine. It increases the duration of action by 4.5 to 6 hours at the risk of hypotension as well as bradycardia, and the third one is buprenorphine with the expense of postoperative nausea, vomiting. There are several case reports. So in order to prolong the blockade, there is the next step, like mixing 1 or 2 adjuvants along with the local anesthetic in order to prolong the duration of motor as well as the sensory blockade. So there are several studies, dexamethasone with the dexmedetomidine intravenously. So there are some clinical case reports that it has extended the duration by 66 hours or 7 days, but it's not been proven in RCTs or meta-analysis. Recent studies have shown that the duration of sensory as well as the motor blockade is prolonged up to the duration of dexamethasone that's being used in order to prolong the blockade. So up to this, all these drugs we have tried in order to prolong the duration of blockade up to a period of 24 hours. But the only drug which has been recommended by FDA for prolonging the duration of analgesia, both sensory as well as motor, is the Exparel, which seems to prolong the duration by 72 hours. Exparel is just nothing but the liposomal bupivacaine. It also contains extra liposomal bupivacaine for the rapid onset. There are several modifications in this, like Exparel, which contains liposomal bupivacaine and Zinrelief and Xeracol. And there are also several studies going on at the selective blockade of voltage-gated sodium channel at 1.7, 1.8 and 1.9. Coming to Exparel, it actually prolongs the duration of blockade by up to 72 hours. It can be used as a local infiltration as well as the regional anesthesia. For local infiltration, 20 ml can be used. For major nerve blocks, 10 ml can be used. For pediatric infiltration, 4 milligram per kilogram dose can be used. Actually, it is a deep foam technology that is encapsulated liposome. Within it, the bupivacaine is placed. It will slowly disperse the bupivacaine up to a period of 72 hours. But this also, it's not far away from controversy. There are several meta-analyses recently that has shown that if we exclude the industry-sponsored trials, the actual clinical benefit beyond 24 hours is not that significant compared to using the non-liposomal normal bupivacaine alone. It comes with the cost of 200 times the normal bupivacaine. Coming to Xeracol, it is nothing but the bupivacaine hydrochloride in a polymer of collagen. It has 300 milligram. Mechanism is dispersion through the pores. Mainly it's been used for the hernia mesh repair. So prior placement, each implant must be cut into 2 halves. 3 halves are placed below the site of mesh placement, and remaining 3 has to be placed below the skin closure. It has some side effects like methemoglobineas, scrotal edema, post-surgical discharge, tremors, and blurring of vision and seroma. Coming to Zinrelief, it contains bupivacaine as well as the meloxicam. It is also a collagen type polymer. it can cause constipation as well as nausea and vomiting. Contraindication, it should not be used in paracervical block, aspirin-induced asthma, CABG, and hypersensitivity reactions. It's been proven to be helpful in bunionectomy, open hernia repair, and total knee arthroplasty. And for TKR, around 40 ml is being recommended to be infiltrated at the time of closure for prolonging the analgesia up to 72 hours. So this is the recent studies that has been going on, but nothing has been proven in the class 3 human trials. But there are several research that have been going on in blocking selective sodium channel, voltage gated sodium channel at the level of 1.7, 1.8 and 1.9, but nothing has been proven of any benefit. So to conclude, only 2 drugs are mainly being used, and that too off-label and non-FDA approved in order to prolong the duration of analgesia. That is dexamethasone and dexmedetomidine. Dexamethasone it extends the duration up to 6 to 8 hours, and dexmedetomidine extends up to 4 to 6 hours. Dexamethasone is not compatible with ropivacaine, whereas dexmed is compatible with most of the drugs. That's it. Thank you.